Welcome and thank you for standing by. At this time, all participants are in a listen-only mode. During the question and answer session, please press star 1 if you'd like to ask a question. Today's conference is being recorded. If you have any objections, you may disconnect at this time. I will now turn the meeting over to Lauren Solkowski, and you may begin.
Great, thank you so much. And good afternoon, and welcome everyone. Thank you for joining us today for the Administration for Community Living's Business Acumen webinar on network development. Again, this is Lauren Solkowski with ACL, and I will be facilitating our webinar. For today's webinar, we have invited representatives from ACL's 2013-2014 Business Acumen Learning Collaborative. They are representatives of the Western New York Integrated Care Collaborative and are here to discuss a report that their collaborative has published entitled Community-Based Integrated Care Networks. So they will be looking at some key pieces from the report and some of the decision-making processes that they use to begin defining their network structure. So before we start with their presentations, I have a few housekeeping announcements to run through. First of which, if you have not done so, please use the link included in your calendar appointment to get onto the WebEx so that you can follow along with the slides, but also so that you can ask your questions when you have them through the chat function. If you don't have access to the link, you can also go to www.webex.com, click on the Attend a Meeting button that's at the top of the page, and then from there you can enter the meeting number. So today's meeting number is 661-512-633. Again, that meeting number is 661-512-633. If you have any other problems getting into the WebEx, please call the technical support number at 1-866-569-3239. Again, that number is 1-866-569-3239. As our operator mentioned, all of our participants are in a listen-only mode. However, we do welcome your questions throughout the course of our webinar. There are two ways that you can ask your questions. The first is is using the chat function in WebEx. So you can enter your questions. That's located on the right-hand side of your screen in the WebEx. So once you enter your question, we will sort through them, through all the questions, and answer them after the speakers have presented. The second way to ask a question is through the audio line. So when that time comes, the operator will give us instructions as to how to queue up to ask your questions. If there are any questions that we do not answer or don't get to during the course of this webinar, please feel free to email them to me. And I will actually, during the webinar, I will put my email address up in a post that you all will see on the right-hand side of the screen. As the operator mentioned, we are recording the webinar, and we will be posting the recording, copy of the slides, and a transcript on the ACL website, as well as on the MLTSS Network website. So again, I will enter this website and the MLTSS website address in that chat box located on the right-hand side of the screen throughout the webinar, and you'll be able to access it there. Okay, so with that, I would like to introduce our speakers. First is Ken Jeanwick. Ken has been the director for the Niagara County Office for the Aging for the past 4 years, leading his organization's mission to promote independence and quality of life through directly and collaboratively provided community-based services to older adults and caregivers living in Niagara County. Ken's diverse private and public sector professional health and long-term care experience and education background, including a Master of Business Administration degree with a concentration in health systems administration from the University at Buffalo allows him to bring a unique perspective on aging and its dual impact on both the system and individual. Our next presenter is Diane Euler. Diane is the coordinator of neighborhood services for the Erie County Department of Senior Services. Her key responsibilities include collaborating with public sector agencies and community-based organizations to coordinate, evaluate, and improve services for older adults and the disabled, including identifying new resources to expand services. And lastly, we have Randy Hoke. Randy serves as the Commissioner of Senior Services for Erie County, New York. Commissioner Hoke's demonstrated leadership in long-term care and home and community-based services brings a professional perspective informed by frontline experience working with frail elders, caregivers, and people of all ages in need of assistance. Randy has previously held positions at the Erie County Medical Center Corporation and the Town of Hamburg Senior Services Department. So welcome to all of our speakers again, and thank you so much for joining us today. Ken, I will turn it over to you.
Thank you, Lauren, and it's a pleasure to be presenting here today with my colleagues, and I'd like to welcome all of you that are a part of the webinar. Lauren, if you can go to the next slide, please, it'd be great. So really the discussion that we're going to have today and what's ahead is we're going to discuss with all of you the aging network in Western New York and certainly not only the network but what we are looking to accomplish as a collaborative with the backdrop of all the changes that are taking place in New York State. We also want to talk about community-based integrated care networks, what these networks are, what we've learned about these networks, and I think more importantly their value and utility that we're seeing here in New York State and in Western New York. We also want to talk about the state of our network, where we are at in the phases that we presented in our report, and then of course at the end we'll have time for questions and answers. So next, please. New York State, known as the Empire State, and New York State is aging like all other states across the country. Right now there's almost 20 million people that are 60 or older, which is about 20% of the, almost 20 million people in the state, 20% of which are 60 and older. Sorry, I couldn't read my own slide. Most live in densely populated downstate area. For those of you who aren't aware of New York State, you basically have New York City, downstate, and then what else is the rest is considered upstate. When we think of New York State as aging, though, as we mentioned, there's approximately 20% are 60 or older. Also, we need to include in there, for purpose of our discussion, is that there's over 3 million caregivers that live in New York State that provide assistance for their loved ones as well. Next, please. Western New York is obviously on the western end of New York State, and you can see that there are 8 counties that make up Western New York, with Erie, Niagara in the top left. We mentioned that roughly 20% of New York State is 60 or older. Western New York itself is above the state average. About 22% are 60 and older. About 1.6 million people that are served across these 8 counties. And really, Western New York is considered the Buffalo-Niagara metropolitan area, and so as we are, really responsible for our local counties, it's important to point out that functionally, Western New York is really considered the metropolis. So when you think of the way consumers, media outlets, and companies view this area, they really consider Western New York to be really one big region. There are a few cities, most notably Buffalo and Niagara Falls, but largely suburban and very rural as well. And as I mentioned, it's served by 8 county governments and really 8 different area agencies on aging. Next, please. So the aging network in Western New York, as I mentioned, is really county-based area agencies on aging. Really, just to take a step back, when you think of New York State, Unlike a lot of other states, we are by far have more AAAs than any other state. There are 57 counties, and there are 59 area agencies on aging. So when you think of your states and how AAAs are set up, in New York State, we are by far have the most. We have 59 different across New York State. Also, when we think of the Aging and Disability Resource Centers, ours are also county-based, and all of these ADRCs, or Aging Disability Resource Centers, are housed within the AAAs. So therefore, you have 59 AAAs that are also act as dual ADRCs. We have some regional community-based organizations that span, across several counties or across the entire region of Western New York, but we have many community-based organizations that serve smaller geographic areas. And next, please. So the changing landscape, and I told Diane I wouldn't sing David Bowie's song Changes, but you can see that there is obviously changes are happening rapidly in New York State, as they really are across the country, and across the country, of course, is really the Center for Medicare and Medicaid aim at the triple aim driven healthcare, which is better health by addressing the root causes of poor health, providing better quality care, and lowering per capita costs. So that is something that obviously is an aim across the country. New York State is embracing that, which we'll talk about as part of their Medicaid redesign team efforts. Also, that is integrating the medical and social models of care, where I think it was described in our report that there's thinning lines between the medical models and social models of care. And of course, the payment reform that is part of that, and we certainly see that in our networks, where you're moving from your more traditional grant-based type of funding, where people are paid to perform work, and they're paid the same amount consistently, and even fee-for-service, to your performance-based models that emphasize shared risk. Next, please. What that change means for the aging network is that a lot of these changes and opportunities are really placing increased value on traditional services that our aging networks offers. And when you think of the Older Americans Act, Title $3 of being home-based services, community-based social model, wellness, education, prevention, services in the home. There's increased value on those services, which are great opportunities for our network, as well as emerging services that play to those traditional strengths as well, like improving health outcomes, reducing hospital readmissions, as well as focus on health promotion and wellness activities. Also, as part of all these changes, it's bringing new partners to the table to work with the aging network, as well as new expectations and rules to govern our work and our reimbursements. Next, please. Opportunities under the healthcare reform and aging networks that we're seeing nationally, of course, is improving population health by focusing on things such as chronic disease self-management, fall prevention, nutrition, and exercise. Also, hospital utilization to drive down those costs of hospitalization and rehospitalization by focusing on care transitions, short-term supportive services, and follow-up referrals to preventive services. And then long-term care, driving down costs through care coordination, long-term supportive services, and as mentioned earlier, caregiver support, all with obviously improving health outcomes. Next, please. So what changes look like in New York is, as we mentioned earlier with the triple aim, New York State has, since 2011, has engaged in Medicaid redesign through a Medicaid redesign team, and just looking at why this is being done really is to curtail a significant amount of costs. Just research has shown that the U.S. has spent 16% of its GDP on healthcare, nearly two times as much as any other nation. New York State Medicaid, the nation largest at one point was spending $53 billion to serve 5 million people, which is twice the national average. And so, obviously it's an initiative at the state level to reduce those costs significantly. And so Medicaid redesign, by initiating a global Medicaid spending cap, has looked at reforming both, their long-term care, but also instituting several initiatives, one being the Balanced Incentive Program, or what we refer to as BIP, which was a state award to New York State from the Center for Medicaid and Medicare Services to expand our New York Connects programs, but also try to help provide greater access to non-institutional long-term support and services. And then, of course, a huge initiative of the Delivery System Reform Incentive Program, which is really the goal of reducing avoidable hospital use by 25% over 5 years. This is up to $6.42 billion allocated to New York State based upon achieving predefined results. And so obviously there's a lot of change happening in New York State and happening as we speak, as it is, I'm sure, in all of your states as well. What we've seen, though, is there are new partners that are emerging to be able to move ahead with, which New York State Department of Health, hospital systems, performing provider systems through DSRIP, as well as Medicaid long-term care plans. Next, please. So what's needed and expected that we've identified, over our time being part of this collaborative is to really increase our local capacity to deliver services. Also have the ability to deliver services consistently and inexpensively. And I think when you talk about, local governments, particularly county governments that are trying to work as a region, the terms, consistently and inexpensively really are the goal, but it can be difficult, when you're looking at scaling up, if you will, as a collaborative entity. And then, of course, the ability to serve a large geographic area in a collaborative manner, really to better meet the needs of customers and engage and work with partners that are looking to work in a regional capacity. Next, please. And up next is how are we going to do that, and I'm going to pass it along to Diane to talk about our involvement in the Targeted Technical Assistance Initiative beginning in the spring of 2013, who's going to talk about lessons that we've learned.
Yeah, thank you, Ken. Absolutely. Like all of you, we were lucky to be a part of the Business Acumen Learning Collaborative. We were part of Cohort 1. As Ken just walked through, we were facing a lot of change here in New York State that was driven by healthcare reform on the national level. So our State Unit on Aging was calling for us to do a lot of the work that's emerging, and we really didn't know how to do that. So when this opportunity came out with the National Learning Collaborative, it was we jumped on it, and we were lucky to be invited to participate. So if you'll go to the next slide, please, Lauren. So in terms of the early lessons, I guess the good news was that we definitely have services that are increasingly valued by the healthcare system. Now we need to direct our energy to scaling up our local programs and learning the new rules of the road. So during our time in the Learning Collaborative, we learned a couple of things related to that. The first thing is you really need to build up capacity pretty quickly. If you normally deliver 4 DSME classes a year and reach about 40 people, that's probably not going to be enough for you to secure partnerships with physicians to refer to you on a regular basis. So you really need to be able to build up capacity to offer classes regularly and reliably, for example. You also need to be prepared to work under different payment models, which will require some infrastructure that you may not already have in place, right? For instance, in the collaborative we learned you're probably going to need to get a Medicare billing number to take advantage of some of these new opportunities. To bill for DSME, you're going to need to get accreditation for your program. You're likely to need to build new systems to monitor quality, do reporting, undergo audits, all of those sorts of things that go along with that new business. So we understood that that was a lot for any one organization to do on its own. So one of the biggest takeaways from the Learning Collaborative was, rather than try to do that and go it alone as a standalone organization, AAAs and their community-based partners should really work together to do these things as a formal network. Next slide, please. So the ACL has been encouraging all of us to look specifically at what they call community-based integrated care networks. As they explained in their original request for applications for the first Learning Collaborative, those networks are very similar to independent physician associations, or IPAs. An IPA serves as a vehicle for private practice physicians to get together. It allows the physicians to address issues together without losing their independence. The signature characteristic, of course, of an IPA is that it serves as a vehicle for physicians to negotiate and contract with payers. Next slide, please. In the time that we've been looking at community-based integrated care networks, we've found that they're even more similar to rural health networks here in New York State. And rural health networks are across the country. I don't know how many of you are familiar with them or not. I know a lot of people haven't heard of them before. But like an IPA, they also bring providers together to pursue common goals. Where they're a little different is that they bring different provider types together. For instance, they'll bring together a hospital, an ambulance service, physicians. And here in New York, those can also include county governments, such as county health departments. So they're very similar to where we want to go, and they can look very different from one another depending on the needs of the communities they're serving. Their form follows the functions they're going to have to perform. So as we've been working through our own network building, we've definitely been keeping an eye towards those rural health networks, and we also have a partner agency at the table that is part of a rural health network that's been helping us quite a bit. Next slide, please. So in terms of how they can help, while in the Learning Collaborative, we learned a lot about the different ways that they can do that. For us here in New York State, where services are very county-based, they can absolutely increase your geographic reach. They certainly help to provide economies of scale so that labor-intensive activities like going through an accreditation process can benefit more than one organization. They can provide a single contracting point, so it's easier for buyers to do business with providers. And they can perform a lot of the common business functions that are needed, such as billing and doing data analytics. Next slide, please. So all of that sounded good to us. When we were in D.C. and we were learning more about these networks, it sounded good to us. But when we brought these lessons back to New York State and to our partners wanted to know if these kind of networks made sense here in New York. And if they do, what kind of network should we build? What should that network look like? If we were going to build something, we wanted to make sure it made sense for our community and was a fit for our needs. Next slide, please. So every state's regulatory system is a little different, so we really needed to look at the situation here in our state and map out the best course of action. To do that, we needed a little help. So we secured some help from a local foundation partner, and we certainly would encourage everybody to seek out such partners themselves. Our partner is the Health Foundation of Western and Central New York. They had been supporting our Learning Collaborative experience in a number of ways already. For example, they had funded several of our network partners to attend the 2013 N4A conference to kick off our Learning Collaborative experience. So when we came back with these questions about network building, They were very receptive to sponsoring our work as we took a closer look, a systematic look at integrated care networks and building them here. So with their help, we've been working through a 3-phase process. During the first phase, we set up a steering committee and developed a work plan for taking a really deep look at networks during phase 2. Phase 2, or the study phase, the fact-finding phase, resulted in the report that the ACL shared with you. It included our recommendations for moving forward with our network building. And now we're in phase 3, which is the implementation phase, which we're going to describe to you in a moment. Before we do that, though, we just want to give you a better sense of what we looked at when we were developing that proposal. Next slide, please. So what we felt we had to look at were 4 big questions. Okay? First, what does the regulatory landscape look like here in New York State? As we're going through this, Medicaid redesign has been unfolding in New York State. So every time we think we have one thing figured out, the state has thrown something new at us. So it really took time for us to get our arms wrapped around all of that regulatory change. So we had to look at what the landscape looks like in New York State. We had to look at what kind of network structure could help us maneuver in that landscape and position us to be stronger partners. Once we identified the type of network that could help us, we had to address whether or not that network was achievable in New York State in terms of dealing with personality types and politics and just the reality on the ground. And the last question we had to answer when we took stock of all those things is, what would we need to make this network happen? Next slide, please. So when we looked at the regulatory landscape, just to give you a sense of that, we found that the emerging needs in New York State are very similar to what others are reporting across the country. We had suspected that New York State was different. Some of you may be suspecting the same thing about your own home state. It's not that different. It may look different on the surface, but once you dig in deeply, the dynamics that are unfolding are nationally driven, so what we're seeing is very consistent. There's definitely a need for our services, whether that be health promotion or care transitions or caregiver services. That's definitely there. There's definitely a need for our local capacity. You've probably been hearing a lot about our value for having feet on the street, right? So they definitely need our local capacity. Services need to be delivered consistently and reliably wherever people in need of services are. But there are some new expectations as well. The most important one that we have to address here in New York State, again, is that need for regional reach, which may seem easy for you guys because a lot of you are organized regionally already. But New York State has traditionally had a very strong county-based delivery system for many services, and that's changing now. New opportunities are opening up, but to take advantage of them, organizations are expected to have reach beyond one county. There is also this is very different from our traditional system, which really has emphasized neighborhood-based services within one county. And then looking on the horizon, payment reform is also going to be impacting us. Right now, we're still finding that grant dollars are still flowing to spur program development, but things are starting to change. Grant funders are increasingly asking us about our sustainability plans. They're increasingly encouraging us to talk to the performing provider systems that were set up by DSRIP or accountable care organizations. So there is definitely an emphasis from switching from grant-based business to negotiated contract-based business. Next slide, please. So given what's happening in New York State, we definitely felt that an integrated care network could definitely be helpful. Our appreciation for that grows every day. I think Randy will tell you a little bit more about that soon. But the question is, if we're going to set that network up, what did we need it to look like? We identified a couple of big things. Number one, the opportunities are coming up all the time. We were telling Lauren before we got started, sometimes our network development work has been slowed because while we're developing the network, we're also responding to program development opportunities. So because opportunities are coming up all the time, we need to be able to establish this network easily and quickly. The second thing is we need the number of funders and buyers in the system are increasing. We're not just working with the State Unit on Aging anymore. We're seeing a lot of different types of buyers and funders. So we need something that can help us to build and manage relationships with those funders and buyers and the people that will refer business to us. We need something that can perform key business functions. The most important ones include going after the new business in the first place, but then also taking care of all the administrative work that comes along with that, from managing the contract to reporting and so on and so forth. And the last one, which really comes primarily from our CBO partners, whatever we build has to help insulate the collaboration from political dynamics. AAAs here are county-based, so they want to make sure that whatever we build, if the cast of character changes, this work can still continue. Next slide, please. So with that menu of things in front of us, we turn to looking at several of the network models that we were introduced to while in the Learning Collaborative. Some of you may have already been introduced to some of these, things like the super messenger model, clinical integration models, primary provider models, which we learned more about on webinars like this. So all of those models can kind of blend together when you're first learning about them. So we wanted to really take stock of what each one entailed and then compare those to what we need. Next slide, please. So if you take time to read the report, in this section, this table basically summarizes how we went about doing that model-by-model comparison. We looked at 5 different models and about a dozen different network functions that we identified that we would need going forward. For each of those functions, we identified if it was something that a particular network type could perform. We also identified whether there were local examples of that function already being performed by an organization. So if we had it locally, it's a large X. If it's something the model could do, but it's not available right now, it's a small X. This helped us to take stock of what we already had here in place in Western New York and what we would need to move forward. So, for example, you can see we have a large X indicating that we have MOU-based coalitions that are helping partners to get to the table and are providing regional reach beyond one county. They don't provide much more than that, though. That's the model in the first column. At the other end of the table, you see that we do have local examples of primary providers performing network functions on behalf of CBO partners. All the AAAs in New York State, for example, are primary providers that perform key network functions for their local aging network already, providing IT services, for example. But they don't have regional reach because they're limited to the county. So in all cases with the models that we looked at, we were missing something that we needed moving forward. Okay? So on that note, I'm going to hand it over to Randy, and he's going to tell you a little bit more about what we've been doing here locally, what's working, and then where we're heading with filling in this network model.
Thanks, Diane. Good afternoon, everyone. Yes, as Diane said, I'm going to talk about what's currently working, what's been working for a little while here, what we need, and what we are doing about it, and what we plan on doing about it. So Diane mentioned this MOU-based coalition, and that's working here. That has been working here, and we have an example of success where we've been able to partner with. I'm sorry, next slide. I'm going to forget to do that, so you're going to hear Diane and Ken saying next slide. So these MOU-based coalitions, we've been successful, and we have a definite example recently where we're able to secure some funds to the New York State Department of Health to deliver caregiver services. And this has been great. It's been a very positive experience. We've engaged some of the partners that have been on board with this collaborative all along, as well as some new partners. What's been nice about it is it's really highlighted and reinforced some of the needs that we've identified in the earlier part of this presentation, and it helps us to do something right now. And that was one thing that we identified. We need to do something. Our partners were looking for some tangible results. However, it's a little clunky to work under this arrangement, especially if you're going after funding for a program that's going to be delivered in 8 counties. So we're talking a lot of MOUs, a lot of time that could be saved if there was a different type of network available to execute some of this work. The other thing that works, next slide, thank you. The other thing that has been working here is the primary provider model. And this is a model that's very familiar to AAAs in Western New York, and I'm sure across the country. A lot of this work we do already, and they're really network functions. We perhaps didn't think of them as network functions before we had the opportunity to join the Targeted Technical Assistance, but we've been able to identify these as resources that can be helpful. So this model will help us to leverage existing infrastructure and maximize our existing relationships. So it gives us the opportunity to be cost-effective partners, and as Diane had mentioned, it insulates, or one of the concerns that we have is the political dynamics of a government-based environment. So that is very prevalent in these primary provider models. There's political turnover, there's turnover in staff, there's changes in policy and direction of the governmental entities. So next slide, please. So we have been able to identify some needs that we've looked to address incrementally over time. Certainly the geographic reach is a need that we've been able to convey, but also the short-term need for quality improvement and relationship management. That was certainly lacking in the 2 models that we had experience with locally. And also, this continues to be a learning experience for us, the need to take on financial risk as we move forward with these partners. So working under the, next slide please, working under the constraints that we've kind of set forth with a better idea of what the needs are locally, we started to identify what we can do next. What do we need to do immediately, and what are the things, some of the low-hanging fruit that we can address. So those priorities are regional reach, certainly, low cost, and the ability to grow and change over time. Because as we were able to stress early in the presentation, we are in an environment that is under a great deal of change and pressure to change. Next slide. What was a very valuable experience for us, probably about halfway through this process, was to sit down with some folks that worked in a clinical setting, but had gone through a similar process and similar evaluation years previous to us. And this was a group of the Safety Net Association of Primary Care Affiliated Providers of Western New York. They call themselves SNAPCAP. But they were not a very formal entity at the outset. This was a group of primary care providers, leaders within those providers, that really met on a very informal basis and would describe themselves as more of a coffee club. They then transitioned into a limited liability corporation when the needs that were impacting their sector became apparent to them. And then eventually they went on to 501c3. And they are a central part of one of the district performing provider systems in Western New York. So they were able to point us in several directions of work that we needed to do right away. Next slide. Probably first and foremost was seeking legal advice. And this is where we really were able to get the ball rolling. And I think it's very important that if you find yourself at this stage in network development, to make sure that you have the appropriate legal advice. And our partners at SnapCap were able to refer us to an attorney who really is considered an expert by many on not-for-profit law, governance, and the like. So he was able to put a lot of these terms, answer a lot of these questions for us, for our partners, for our county leadership in relatively easy to understand terms that we could bring back to our leadership and our partners could bring back to their not-for-profit board members. Next slide, please. This was not as easy as we thought it would be. When we participated in our TTA cohort, we heard a lot about LLCs. And there was a number of regions within the country that were looking to go in that direction or had been successful in developing networks through an LLC model. And after a couple meetings with the attorney that we're now working with, we decided that wasn't going to work well in New York State. So and we decided against it because of the very difficult transition in New York State to go from an LLC to a 501c3, unless you structured that LLC in the state of Delaware, which was the loophole that the attorney provided for us. If we wanted to do an LLC, we could. It would be relatively easy and quick, but it would have to be in the state of Delaware, and then we could, down the road, convert it to a 501c3. As we've stressed in this presentation, we are local government entities, and we thought that that would be a little awkward to propose to our county-based and state leaders to establish an LLC in the state of Delaware. So I just stress this point because it's an example of the political concerns that often need to be considered in this work. It certainly was an interesting conversation, and eventually we were able to identify the vehicle that we needed, a taxable not-for-profit corporation. And that's where we are focusing our efforts on right now. So the New York State law allows this entity to begin, to become incorporated, and to begin to function while the bylaws and other governance issues are being hammered out. Next slide. So where we are right now, we're continuing to build this as we go. The Health Foundation of Western and Central New York is continuing to be a great partner, and they're covering the costs of incorporation while we work with this attorney and our partners. We are looking at identifying the 3 members that are going to start off this process. We're really looking at leadership and discussing with the leadership from our counties what our role is going to be, what that's going to look like, what the implications are within county government. And we're also engaging our steering committee in that conversation as well. We are really making sure that we allow the form to follow the function as programming develops. So we've given you a few examples of what we're looking at programming-wise, some of the health promotion activities, the diabetes self-management, care transitions, this caregivers grant that's been a regional application. So as those needs arise, we are looking to make sure that the function of this network is going to address those as they come up. Next slide, please. What's been very important for us to remember is that as we get moving, we will find the answers to we found the answers to many of these questions as we've worked through some of the issues. We learned from some of the other organizations, the other participants of our cohort, that it can be very easy to get stuck on answering a question before you move along. And what we've found is a lot of this work needs to be done in parallel tracks. So some of the work that remains that we are looking to address in this next phase is what's the ownership and governance structure. As we mentioned, we have some ideas as far as the direction that we're headed there, but there's a great deal to be hammered out yet. What does membership mean? How does an organization become a member? What's the value to that organization? What limitations may they have as a result of their membership? What circumstances can a membership be revoked? And how can we cover startup and ongoing administrative costs? So there's been several opportunities that we've worked on under this philosophy without putting a lot of the covering some of the legal questions, but looking forward, the partners that we've had at the table and the newer partners, due to some of the other initiatives that we're working on, they've been able to see the value in the concept and the model that we've discussed and that we're moving towards. So that's all I have for right now, and we are really eager to hear what your questions may be.
Great, thank you, Ken, Randy, and Diane. Thank you so much. So we will start the Q&A portion now. So operator, if you could please provide instructions for asking a question through the phone, that would be great.
Thank you. If you'd like to ask a question, please press *1. Please unmute your phone and record your name when prompted. It is required to introduce your question. Once again, that's *1 if you have a question.
Thank you. So while we'll wait for questions to come in, I actually had a question for you guys. So, and I know this is something that we've heard from our current cohort in terms of, getting your foot off the ground and, making that initial step. Diane, you had mentioned you made a connection to the foundation, the Health Foundation of Western and Central New York. So my question is, how did you make that initial connection with them?
Well, in the case of the Health Foundation of Western New York, I think we are lucky in that they fund projects in two areas exclusively. One is for children, 0 to 5. The other is frail elders. So they had been, they've only been around, I think, about 15 years now. But since the beginning, they've really been very good partners to the Aging Network in their territory. So we happen to be involved in another capacity building grant effort that the foundation had underway at the time, called Ready or Not. And so a lot of the work that we were planning on doing with our Ready or Not grant, when this opportunity came forward with the Learning Collaborative, it offered us a way to do a lot of that work and get the resources from the ACL for free. So that kind of gave us an automatic opening to talk to the foundation about this. They were excited from the beginning because it did complement their existing efforts so well. But really, I think that a lot of times people make the mistake of viewing grants in isolation. So when they have, a lot of your cohorts may have existing grants and regional partners already that are helping them to do work at point A, and they need to make sure they're connecting the dots. And that's what we did with this. When we received this, we automatically communicated that success to the Health Foundation of Western and Central New York. One of the first things you guys did was encourage us to get our partners to the N4A pre-conference intensive in 2013. We automatically said, okay, let's ask the foundation to do that for us, because we knew that this was consistent and in alignment with their own goals and mission and vision. And it starts with a phone call to your program officer, your local program officer, to see if there's interest, and then once that's in place, writing a pretty short proposal, a 2-page proposal, outlining what it is that you want to do, and keeping them posted of your successes as you go. Don't be shy about your successes. You've got to build up that excitement in your local foundation partners, and always connect back your success to the things that they're interested in. So that's how we've been able to leverage that relationship with the foundation. And they've gone on to build new relationships themselves with you guys, with the Hartford Foundation, with SCAN. So it's been a win-win. So I think wherever you have a win-win, you can certainly make the case with your local foundations.
Great. Thank you so much. Operator, I'm checking back to see if we have questions come in on the phone.
Currently, there are no questions. Once again, that's star one if you'd like to ask a question.
Thank you. Checking, we don't have other questions on the chat, but I did get a note from it's the California Association of Adult Day Services, and sort of she mentioned that they're just starting to build a network and would like to bring all of their adult day health care and adult day services together as one unit. So they're just starting this work. And so she indicated an interest in connecting with you all, maybe through their executive director, to talk, more after this webinar, to learn more.
Sure, we'd be happy to do that.
You talked about today. That would be great. So I'll make that connection following the webinar. Okay, I'm just checking my box here. Let's see.
I do think, if I could just add, Lauren, I mean, that's a great, I'm glad to hear that there's a group of adult day providers that are looking to organize in that way. I believe that, and it was our experience in our work, in our cohort, that state associations or associations of specific agencies can be helpful in these. I know that there's a state association, I believe, in Pennsylvania that was a participant of our cohort, and if the willingness is there, if the capacity within the association, that's another place to look, because they may be structured in such a way to have that regional reach, and also, the contracting, the QI, there's a great deal of potential there. And what we've found is we've had more conversations with medical providers that there's associations that function in that way on the medical side, that have been able to really model what we're looking at in New York as well.
Oh, great. A question that came in via chat is what was your timeline for this network implementation?
Well, we've gone over time. I'll tell you that much. I think that originally we were hoping to get something going before our cohort ended at the end of 2014. It's been really difficult to maintain a timeline for several reasons. Number one, during our fact-finding phase, we secured consultants to help us unravel the regulatory picture here in New York. Working with some consultants, it alters the timeline, and new questions keep popping up. It was while we were in the early stages of building or looking at building this network that all of a sudden DISRIP hit in New York State, and a lot of attention got diverted to that. And so maintaining a timeline's been difficult. We originally had these conversations with the attorney early last fall, I would say. So at that point, we were right in Erie County. We were at a point where we were going through a county executive election. So we have to kind of wait for the election calendar to catch up with us. But in terms of once all that settles, getting it done is short. It's very quick. the incorporation itself can take a matter of weeks, according to the attorney. And now we're at the point where it'll go as quickly as we are ready for it to go. The incorporation papers are pretty much ready to go. We just have to identify our 3 directors, just get the final okay from our county executives. We're meeting our partners again tomorrow. We're hoping to have this in place within the next, what would you say, guys, month?
Yeah,
2?
hopefully.
Yeah.
Mm-hmm.
Yeah, I think it's important maybe just to talk about what Diane had mentioned as well, is that, we obviously came in with plans and goals and timelines, but, so much happens, and it's not unlike anyone else is experiencing in their work, is you have your day-to-day operations that you run, and the landscape changes. But, I think what's been great about what we've done is that, we've run into roadblocks here and there, but we've kept the conversations going. And, it gets discouraging at times if you aren't meeting your self-imposed deadlines. But just the fact that, you keep it going and you don't stop at a roadblock or a dead end. Randy mentioned earlier this caregivers initiative that we were able to work with, and frankly, we got 7 counties to collaborate with a regional not-for-profit to be able to apply for a grant that's a 5-year grant to help provide caregiver relief for those caring for individuals with Alzheimer's disease. It's an initiative that, had we not started this targeted technical assistance in 2013, we never would have been able to come together as quickly as we did. And even though we certainly, it's been helpful to learn what one of these not-for-profit corporations can do for us to make that quicker, that effort would never have been put together had it not been for this initiative. And so we found success in other arenas that would not have been built had we not had this relationship.
Right. And I think the only other thing I would add, Lauren, is that as our CBO partners had been the more seasoned ones who had experience in the rural health networks, sometimes when you're doing the network building, when you're trying to justify going from a coalition of partners to doing something more formal, you really need to have a reason. And I think that comes, so all of a sudden an opportunity will come your way that really requires you to make the change. So to go back to the SnapCap example, our primary care friends, they were a coffee club until, they had until health homes came along. And all of a sudden it made sense for them to become an LLC. Then the transition from LLC to 501(c), that only happened because they needed to have nonprofit status to make another move that they wanted to make with Disrupt. So you've got to have a trigger to justify going from one step to the next with the network formation, is what we found here locally at least. People don't want to just build something for the sake of building something. That's why we chose this particular type of model, where you can go, we can get the paperwork in place, we can be incorporated, we're actually a thing, it's real and tangible. And then as opportunities present themselves, you can become more and more structured and flip from from a taxable nonprofit to a 501(c) as the need arises. That's what we mean by form following function. So,
right.
Yeah, so with this Alzheimer's grant, we've really found that, we can get partners together with MOUs, but as Randy said, getting the contract in place, doing the work plan, and it has been a bear. And I think every time one of these opportunities comes our way and we're not prepared, people realize the need for that network. And I think you need to have that trigger.
Yeah, the other thing when it comes to that specific issue is we are at the mercy of the regional partner that may or may not be available at the time. So the mission could change, the leadership could change. We can have an established partner for years that we may look to at an opportunity that comes our way, but things change, and folks that have worked in and among the not-for-profit world, they know that well. I'd also just like to echo the reason. That is critical. there's a temptation, and this came up several times throughout the course of our interaction with some of our partners. There's a temptation to identify who this is going to be.
Yeah.
Who's going to be running this? How are we going to pay them? Where are they going to work? Where is their office going to be? Or where is a building going to be? And we have successfully dodged any of those commitments to this point because we want to protect that reason. I'm sure that many other communities can relate to, seeing not-for-profits merge more and more. A call for not-for-profits is to merge. So when you're presenting your community with another not-for-profit, that reason becomes all the more important.
That's great. So I guess another question well, actually, let me check back with the operator before I go back to the chat. Are there any questions on the phone?
Yes, we do have a question from Kristen Jeffries. Your line is open.
Am I on?
Yep. Hi, Kristen.
Okay. Hi, this is Kristen Jeffries with the Wisconsin Institute for Healthy Aging in Madison area. And I had sent a question over the chat as well. And you may have answered this, but could you comment on the proposed financial arrangements, the startup funding for the network? How will the network be funded to perform the administrative functions listed in the table? And Randy, you were getting at this a little bit, but if you could comment on where the startup funding is coming for this.
Sure.
Please.
The startup funding to date has been provided for by the foundation, the Health Foundation of Western and Central New York. So moving forward, we are looking at several possibilities. I would say the primary possibilities is through reimbursement for delivery of services, as well as grant revenue through perhaps indirect costs that may be associated with different grant programs.
Okay, so taking a certain percent of either the reimbursement revenue or the grant revenue and assigning that to the administrative and support functions of the network of corporation. Then.
Yes,
okay.
that's something that we're looking at.
I think.
And is it also possible that the network member organizations, and granted most of them are county organizations or county governments, perhaps some private nonprofit CBOs, would they be also asked to contribute a certain amount to the as a member to the network as a ongoing annual fee or anything like that?
Yeah, that's something that we've discussed. And that's something that that other organization, SNAPCAP, that I had mentioned, that they had instituted at one point. I'm not sure if they still have that membership organization structure, but it's certainly something that we'd be willing to consider. But it's really not. I wouldn't say that it's really the primary method of financing. We're not looking at that becoming really the sustainable income for the network.
I think one of the most important things we've grappled with is this question, and there's a real hesitancy to build something that's really large in the beginning that's going to take a lot of capital to support, because the idea of building this network is to help be a revenue generator for the member organizations, not a revenue consumer. So we really are looking at low-cost ways and really building it out as the need arises and the revenue for doing those services is coming in. So we're really trying to keep that in mind. And I think an important indicator for us is that when we did sit down here in Erie County and talk to our county executive, one of his first questions was, is this going to be another nonprofit that we're going to have to invest a lot of money in? So locally, we have been invited to create another proposal, write another proposal to cover, more extensively the startup costs, but there's not a lot of appetite locally for building a really expensive high-end organization. They're going to have to earn their revenue as they go.
Which I think is why, as we're looking at this, what models make most sense is the not-for-profit corporation is easy to set up, which would allow you to develop a 501c3. But to Diane's point, to build a grand not-for-profit, without having the revenue to go along with it, would not be the right approach we want to take, because a not-for-profit corporation can be small enough as you're building, and frankly not necessarily even realizing any profits, that would be easier to build small.
Right, and leverage the strengths of your partner organizations. That's what we have to do. Right now, I mean, we have, in terms of supporting our network effort, we're using a part-time consultant. So until resources are in place, we're keeping the cost for this as low as possible.
Mm-hmm. All right, thank you very much.
Okay, operators, any other question on the phone?
Not at this time.
Thank you. We do have another question. So this one is asking about, can you talk a little bit more about the type of healthcare partnerships that you have now? And are you getting paid for those services as you more formally form your network?
I think the most important one that we're partnership that we're looking at right now is with our local performing provider system and our hospital systems. The way we're doing a lot of our program development work, one of our first lessons we learned, and it was from the folks in Merrimack Valley, was you've got to demonstrate your value. So we've had a pilot program in place with our local hospital called Ready, Set, Home that basically works on care transitions from hospital to home. The grant funding for that is winding down. So those, and interestingly now, they're looking at us because they have experience with us and looking at us being part of what they're billing as rapid response teams to deal with hospital-to-home transitions. We haven't started talking about compensation yet, but that would be an example of an emerging partnership. Apart from that, we're aggressively working on building up our capacity to deliver reimbursable DSME and put that in place to get the Medicare reimbursement for that, apart from any specific partnership.
Okay. Another question that just came in, are you still doing credentialing when organizations join?
We haven't filled out what the credentials would be. I mean, as AAAs, there's provider credentials that we must have if it's going to be for a social adult day or for a home care agency, those sorts of things. So to the extent that you're dealing with existing services, we fall back on our existing AAA credentialing. But as we're moving forward with accreditation, whatever the accrediting body requires in terms of those credentials is something we would have to, just as you do now with in your AAA capacity, you're just going to have to make sure your partners, if you're doing medical nutrition therapy, they have to be a registered dietitian. If they're going to be supervising DSME classes, they have to be one of the acceptable clinical types. So that's all part and parcel depending on what program you're developing or pushing out.
Right. Okay. Just checking quickly. Okay. Operator, any other questions on the phone?
No, there are no questions at this time.
Thank you. I will give it another minute or so just to see if we have any last minute thoughts from anyone. Oh, sorry about that. So yeah, let's just wait another minute and then.
While we're spending that minute, I just want to say that our email addresses are up there, and we found that to be a very valuable interaction throughout our cohort of the targeted technical assistants. And there was plenty of phone calls between folks in different parts of the country to just kind of clarify, throw out some clarifying questions and seek their counsel as well. So please, we'd be more than happy to talk to you offline if you have questions that occur to you later on after digesting this or after having a conversation with a colleague. If there's something that comes up that you think we may be helpful with, don't hesitate to call or drop us an email.
Excellent. Thank you so much for that, Randy. So I'm showing no other questions at this time. So I think we'll get ready to conclude. I just wanted to thank Ken and Diane and Randy again for joining us today and for such a wonderful, comprehensive presentation. Thank you so much. Thank you for all of our participants and for your questions for them. They were great. Again, if you think of any other questions once we hang up, please feel free to email them to me. My email address is listed there in the chat box on the right-hand side of the screen. So just thank you again to everyone, and enjoy the rest of your day.
Thank you, Lauren.
Thank you guys so much.
Bye-bye.
Bye-bye.
Thank you. That concludes today's conference. You may disconnect at this time.
Thank you.